Okay, so hello everyone. Today we will be talking about basics of pediatric imaging. So first we will discuss about the technical consideration in pediatric imaging. So we have to know that in pediatric patient we have to minimize the heat loss. Now why is it important? Because the premature babies, they usually have less subcutaneous fat. So there is more risk of heat loss. So what should we do? First of all, we should maintain the room temperature at 27 degrees Celsius. Okay, then how can we maintain heat? On the tabletop there can be some heating cradles, okay, which can heat the baby. Then is there anything else which we can do while doing the ultrasound? Yes, when you do the ultrasound, you place the ultrasound probe inside the incubator via a porthole. In the incubator there is a porthole and you push your probe via that porthole into the incubator and then do the ultrasound. So you are basically not opening the incubator. That means there will be less chances of heat loss by convection. Next thing that you have to do is please use warm jelly, because if you use warm jelly there will be less heat loss via conduction. Okay, so this was about minimizing the heat loss. Second thing, because the babies, they usually are not very cooperative, so we have to immobilize them. How we will immobilize them? What are the aids that we can use? First, you can use a blanket. You can tightly wrap the baby in that blanket and then do the x-ray maybe. The second thing that you can use is gauze pads with tape. So you can take some gauze pad and put tape all around them. You can also use vendor provided pads that we use in CT, or you can use sandbags and you can put them on either side of the baby to immobilize the baby. Next thing, you can use maybe wooden boards. They are usually used for old and stronger children, so we will tape the baby to this wooden board. Another thing that we can use is a cradle, and cradle is usually used for infants. So these are the various things with which you can immobilize the baby. And can you imagine that if you use these devices, there is a possibility that they may cause some artifact during imaging, right? So what is the ideal immobilization device? Ideal is one which should not cause any artifact. Next thing that we have to know is about sedation. So for sedation, there is something which is known as NORA. Full form of NORA is non-operating room anesthesia. So normally the anesthesia is given in OR, operating room, right? Now NORA is non-operating room anesthesia. So here the anesthesia is given by anesthetist only, but it is given outside operating room like in CT room or in MRI room. So should we directly give sedation in the first go? No. First of all, we should try some non-pharmacological method. Now, how can we do CT scan, for example, without sedating the baby? First, you can immobilize the baby. Second, you can maybe somehow make sure that the baby sleeps. Now, how you will make sure that? You feed the baby, then you wrap the baby, you make sure that there is less noise and light around the baby, and usually the baby will sleep. This is specifically true for less than 6 months of age, and then you can do the CT. Similarly, you can also use one technique of mild sleep deprivation. Now in this, what we do is we will ask the parent that there should be 1 hour delayed going to bed. That means you make the baby sleep 1 hour later than the usual time, and you wake up the baby 1 hour early in the morning. So at the time of CT scan, baby will sleep. Another thing that you can use is play therapy. So in play therapy, you will use some toys, some pictures. They will decrease the anxiety of the baby. Secondly, you can also use the help of parents. Okay, so you make them stand next to the baby while he's going CT, while he's undergoing CT, and that's how you can immobilize the baby. And if the child is intellectually appropriate, he understand what you are telling him, then in that child of usually 4 to 5 year or more, you can carefully explain that baby, please cooperate, and he may cooperate with you, and you can do the CT scan without sedation. Next thing, if you have to give sedation, then what you will do? First, you will do pre-anesthetic evaluation, in which you will explain the parents what you are going to do and obtain the consent. You will give written instructions to parents also what they have to do. Because we are sedating the baby, so we have to make sure that the baby is nil per oral. Now, what are the guidelines for clear liquid intake? The guideline is 2 hour time of nil per oral. For breast milk, it is 4 hour. For non-human milk like cow milk, formula milk, or light meal, it is 6 hours. Now we have to understand that whenever there is bowel obstruction or ileus, it increases the risk of aspiration because the content will be accumulating in his stomach. Okay, so in these cases, what we should do? We should do nasogastric suction of gastric contents. We should suck them out. Also, we can give metoclopramide. What it does, it increases the gastric emptying, so it will push the food forward into the bowel, thus decreasing the risk of aspiration. Next thing we have to do after giving anesthesia is monitoring. What you will monitor? Pulse oximetry, BP, capnography. What kind of monitor you will use in MRI? You will use non-ferromagnetic monitor in MRI. If you are using ferromagnetic monitor, please make sure that you place it outside the MRI field or you carefully shield it. Okay, then because the baby can develop complication at any time, so please ensure that there are adequate equipments in that CT or MRI room, like oxygen cylinders, suction machine, a cart with all the instruments, drugs, defibrillator. And what are the sedative agents that we commonly use? So the route that you can use is, of course, IV. Other routes are oral, rectal, nasal. For sedation, we know some drugs from our UG time as well. So we have barbiturates, but the side effect is respiratory depression. Benzodiazepine like midazolam, but the side effect is vomiting. Some narcotics or opioids you can use. And then you have ketamine, propofol. What is the side effect of ketamine? It increases ICP. Next, you also have to know about the risk of anesthesia. So what are the risk of anesthesia? So we have divided it into two categories. First is immediate or short term. So short term, what can happen during anesthesia? There can be hemodynamic instability, that means BP may reduce, or oxygen may reduce, that means less ventilation, which can happen during laryngospasm or bronchospasm. Similarly, because the child is nil per oral, he may have hypoglycemia, he may have hypothermia and allergy to contrast. And what are the long-term effect of anesthesia? Because anesthesia is, somehow acting on brain, so it can lead to some neurocognitive defects in long term. Next thing, sometimes we have to choose one modality, CT versus MRI. We know CT has a short time while MRI has a long time and also long waiting time as well. CT uses radiation while MRI, because it is a long scan, you will require sedation. So sometimes we have to choose between radiation versus sedation. Now this is the most important question, radiation reduction. How will you reduce radiation in pediatric patient? So we know the effects of radiation. These are of two types, deterministic and stochastic. Deterministic effect means that these are dose dependent. As you will increase the dose, these effects will increase. So they are predictable. For example, burns, for example, hair loss. As you increase the dose, these effects will increase. And then there are some stochastic effects. Stochastic effects means that they occur randomly. So there is a genetic change which occur randomly and it can lead to cancer. And to explain about radiation, we have two models. One model is dose related model. Now this model says that there is a linear relationship. There is a no threshold hypothesis, means that there is no threshold. Cancer can occur at any dose. As you increase the dose, risk of cancer increase. So there is a linear relationship. On the other hand, some people gave one threshold model. So they said no, 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 there is a threshold. So there is increased risk of malignancy when radiation goes above a threshold level. Above what level? Above 100 millisievert, which is rarely used in CT. Acha, between children and adults, what do you think? Which has more risk of cancer? Children have more risk of cancer. Why? Because children have more dividing cells, and also children have longer life expectancy, na? So they have more time to develop cancer. Acha, between children, between male and female, which one has more risk of cancer? Females have more than male. So in children, we should use ALARA principle. ALARA refers to as low as reasonably achievable. And similarly, we have one campaign which is Image Gently. What do you mean by Image Gently? This campaign began in 2007, and the main aim was to create awareness to the parents and doctors about radiation exposure and how to do the dose readjustment. Next, acha, before doing a CT scan, what is the prerequisite? The prerequisite is you should properly evaluate the need of examination, whether this examination is actually needed or not, and then choose the most suitable modality, whether it is CT or MRI. So we are talking about radiation reduction. First, we will talk about radiation reduction in radiography and fluoroscopy, and then we will talk about radiation reduction in CT. So first, let's talk about radiation reduction in radiography and fluoroscopy. So we will divide it into two headings. First, let's talk about equipment related factors. So how equipment can reduce radiation? First, we have digital radiography. You know, earlier we used conventional radiography, now we have digital radiography. So in digital radiography, the advantage is that repeat exposures are no longer necessary. You don't need to take the x-ray again. Okay, you can adjust the exposure digitally. And second important thing is digital radiography. In digital radiography, the exposure can be adjusted as per the patient size. So it also reduces dose because you are adjusting how much patient should be exposed. So in digital radiography, you should use appropriate collimation, proper source to image distance, proper patient positioning, and use proper focal spot size. Second thing that we can use is added filtration. So what is the use of filtration? Filtration will remove the low energy X-ray. So it will decrease the dose. And which dose? The advantage is it will decrease the surface, means skin dose, entrance surface dose. But what is the disadvantage? It also decreases the contrast, and it increases the load on the tube because you are using filtration. Acha, which filter do we use? If you are adding aluminium, then 1 mm aluminium. If copper, then 0.1 mm, 0.1 to 0.2 mm copper. And if you are using steel, then it is 0.7 mm. Then what can you do during fluoroscopy to decrease dose? So you should use image intensifiers, modern image intensifier, and use pulsed fluoroscopy, means you should give the x-rays in a pulsed manner. You should not use any magnification. Instead, you should digitally zoom the image to look at that particular area. And while doing fluoroscopy, you can use this thing which is known as last image hold up system. What do you mean by this? This means that you save the last image of fluoroscopy and the cine loop. You don't give exposure. You expose the patient only when increased resolution is needed. When you need very sharp image, only then you expose the patient. Otherwise, just save the last image and cine loop. Similarly, it has been seen that if you use 3D rotational DSA, it reduces the dose more as compared to 2D DSA. So these are the equipment related factors. First was digital radiography, second was added filtration, and third was fluoroscopy. Now we have some operator dependent techniques. That means how the operator or how the radiographer can actually decrease the dose. First of all, field size. This is most important. So you should collimate the properly. And when do you collimate? You should collimate before placing the child on the table. If you are doing chest x-ray, you should collimate before placing the child on table. Now you have to understand, because red marrow is present in the skull above and in the femur below. So you should properly collimate during the chest and abdomen scans so that the skull and femur are not exposed. Second important thing that you can use is automatic exposure control, AEC. So the machine will automatically use the exposure parameters. Third is FFD, film focus distance. That means what is the distance between the film, means patient, and focus, means X-ray tube. So keep the distance as long as possible. It should be at least 100 centimeter. But you know, in ward we have bedside x-rays. In bedside x-rays, the film focus distance is usually less than 80 centimeter. Ideally, at least it should be 100. Should we use shielding these days? Should we shield sensitive organs like gonads? So the answer is no. In today's time, no routine shielding. Why? Because the modern scanners we have, they can detect that shield, and then they will use increased dose, because they can sense that a shield is there. Okay, so paradoxically it will increase the dose to the baby. So do not shield in today's time. Acha, what is the effect of beam direction? Does AP or PA has any value? Yes, it has. So when you do AP, the rays are passing antero to posterior. That means the breasts are exposing first. The gonads are exposing first, right? So instead of AP, what can we do? Can we do prone scan? Yes. So it will become kind of a like PA scan. So what is the advantage? The breast and gonad will be exposed less. There will be less dose to them. Secondly, when you lie prone, then your belly is compressed, right? So it will decrease the patient thickness, and therefore it will decrease the scattering. So this is the effect of beam direction. Should we use anti-scatter grid in the patient? So you have to know that when do we get scattering? We get scattering when a person is thick, obese. The baby are anyway small, right? So scatter radiation do not play very major role in pediatric patient. In fact, when you use grid, it increases the dose. So it has been said that no grid is needed in babies less than 30 kg or whose thickness is less than 12 centimeter. So now the question begins, when you will use grid? Grid is required for obese children. Obese children means whose thickness is more than 15 centimeter. Or when you are using high kV, means more than 90 kV. What type of grid do we use in pediatric patient? 8:1. Next thing, what other thing we have to remember is you have to decrease the fluoroscopic time. So you should not use fluoro continuously. Also, you should use fluoro only after proper positioning. So first properly position the patient, then start fluoroscopy. And keep the frame rate low. When you keep frame rate low, the X-ray pulses are also low. Frame rate should be 3.75 to 7.5 frame per second. So these are the operator dependent techniques which a radiographer can do. So we had field size, automatic exposure control, then we talked about film focus distance, then about role of shielding, then beam direction, AP or PA, anti-scatter grid, decrease the fluoroscopic time, and frame rate. So this was about radiography and fluoroscopy. So in this we studied equipment related factor and then the operator dependent factors. Now we have to talk about radiation reduction in CT. So first of all, CT brain. What should you keep in mind is CT brain should be used mediculously, because I told you there is presence of red bone marrow in the head. Second important thing is about chest. In chest there is natural contrast because there is lung, right, which contains air. So there is a very natural contrast. So in chest CT less dose is required. Then in CT, you can do tube current modulation. So you can do automatic exposure control. Automatically the tube will adjust the current. Now what are the names of automatic exposure control? In different machines different names are there, like care dose 4D, dose right, auto MA. So how do we do automatic exposure control? So do you remember in CT first we take topogram? So CT machine, what it will do, the system will assess the size of the patient and attenuation of the patient based on topogram. And please remember that human body is not circular, it is non-circular. So when the X-rays are passing in AP direction, they are comparatively passing through a thinner portion, while when they are passing in a lateral direction, lateral projections, the X-rays are passing through comparatively thicker part. So lateral projections are more attenuating than AP. So what will tube do? Tube will automatically increase the current when the tube is taking lateral projection, and it will decrease the current when it is taking AP projection. So this was about tube current modulation. Similarly, we have tube voltage. So we should use less tube voltage. It will decrease the dose. So if you use low kV like 70 to 80 kV, it will decrease the radiation dose. How is it related? It is related to the square of voltage. Okay, but what is the disadvantage? If you use low kV, the noise will increase, but the CNR, contrast to noise ratio, will also increase. So this is important. Low kV leads to high contrast. So when should you use low kV technique? Low kV technique you should use whenever you need to increase contrast. Like in CT angiography, you are using contrast. CT urography, CT enterography, hyper enhancing lesion, and in chest also anyway, if you need to increase the contrast. So because with low kV technique you are increasing the contrast, so less contrast volume will be required, and the injection rate will also be less. When can you not take low kV? Low kV is not useful in obese, obviously, because in obese patient there will be too much attenuation of X-rays. In NCCT, because there will be no contrast as such, no, in NCCT. And in implants, because low kV will lead to more increase in streak artifacts due to implants. So at these three places you will not use low kV. Then we have spectral CT. So we are talking about dose reduction in CT. We did tube current modulation, tube voltage reduction. Now we are talking about spectral CT. Spectral CT include dual energy CT, photon counting detector CT. That means in short PCD CT. So what is photon counting detector CT? In this CT, the X-ray photons are directly converted to electrical signal. There is no scintillator in between. So there will be no electronic noise from the scintillator or reflective septa. So because the photons are directly converting into electrical signal, so less photons will be required to give same amount of electrical signal. So less dose is required, and therefore less contrast volume is also required, because better contrast will be there. In dual energy CT also less contrast volume will be required, specifically in low kV images, because I already told you low kV increases the contrast. What is other advantage of dual energy CT? You can create virtual non-contrast images. So it will omit the use of NCCT images. You don't need to take one NCCT scan. Then what are the other ways to decrease the radiation dose? Iterative reconstruction. Intelligent dose modulation by AI. AI can modulate the dose. Then low dose CT and ultra low dose CT. Okay, acha, how much radiation is used in ultra low dose CT? It is sub millisievert. It is almost equal to taking chest X-ray. But what is the disadvantage? You are using such low dose, it will increase the noise and it will increase the streak artifact. So you should simultaneously use noise reduction technique. Now what are the noise reduction technique? In Siemens it comes with the names of Clear. In Philips it comes with the name of Allura Clarity. And next thing, how can we reduce the radiation is you have to improve the awareness. That means you should do real time monitoring by DAP, dose area product, and air karma. So you will know, okay, the patient is getting more radiation, I should modulate it. So that's how you can reduce the dose in CT. So we talked about tube current modulation, tube voltage reduction, spectral CT, iterative reconstruction, intelligent dose modulation by AI, low dose and ultra low dose CT, and improving the awareness. Next thing that we have to know is how to decrease the examination time in CT and MRI. So in CT we know now we have rapid scanning techniques, so you don't need to sedate the baby as such. You can do awake CT, you can do free breathing CT, breath holding is not required. So how you will do rapid scanning? There should be wide area detector and the pitch should be high. That means the CT machine should take more distance, it should rotate more distance in a single go, so it will also decrease the dose. How to decrease the exam time in MRI? First we have automated protocol selection, so the machine will automatically select the protocol. Like in Philips we have smart exam, in GE we have ready brain, in Siemens we have dot. So there is automated protocol selection which decreases the time. Second, we have parallel imaging. Parallel imaging is better for 3 Tesla as compared to 1.5 Tesla. So in parallel imaging, what do? There is undersampling of K space. That means less phase encoding lines will be required. And when less phase encoding lines are required, the scan time reduces. But what is the disadvantage? You are not filling the K space fully, so the signal to noise ratio SNR will reduce, and there will be presence of wrap around or aliasing artifact. Because you are doing undersampling of K space and you are decreasing the scan time, so there is something known as acceleration factor. If you are using acceleration factor of 2, it will half the scan time. Which coil you use in parallel imaging? Multi-channel phased array coil. And because in parallel imaging the scan time is less, so where should you use? In whole body MRI, in MR angiography, in cardiac imaging because less time required, while taking 3D scan of the abdomen because less time will be required. Next, you can take simultaneous multi-section SMS imaging. Means simultaneously you are taking multiple sections in MRI. This is better for 1.5 Tesla as compared to 3 Tesla. So how you do? You will give a multi-band RF pulse. You will give an RF pulse in multiple sections in a single TR. And what is the meaning of section acceleration factor? Section acceleration factor means how many images you are acquiring at a time. Usually it is 2 to 8. So more the acceleration factor, less will be the scan time. It is inversely proportional. Where do we use SMS imaging? In DWI, in functional MRI. In Siemens, it comes with the name of multi-slice. In GE, it is hyperband, and in Philips, it is multi-band sense. Then we have radial K space filling. Radial K space filling, it is best for axial images, and it is better for 1.5 Tesla more than 3 Tesla. The disadvantage of radial K space filling is that you are filling the K space radially, right? So the contrast to noise ratio and signal noise ratio are not good at periphery. There will be blurring at periphery. Usually we use these scans for abdomen, for brain. They come with the name of propeller in GE, multivane in Philips, and blade in Siemens. And then in the end we have compressed sensing reconstruction. Again it refers to undersampling of K space, and there is a long reconstruction time, more than 30 minutes. I know this much portion was actually very difficult to understand, but even if you remember the headings only, that is also good enough. So how to decrease the examination time, automated protocol selection, parallel imaging in which we are doing undersampling of case space, simultaneous multi-section imaging, radial case space filling, compressed sensing reconstruction. Then we have the use of contrast media. So what do we need to know about contrast media in pediatric patient? So before putting cannula, please make sure you apply a topical anesthetic gel for half an hour, and then you put the cannula. It will be painless to the baby. Then please use warm contrast media. It will decrease the pain and it also decreases extravasation. Which contrast media we should prefer? Low osmolar or isoosmolar? So low osmolar monomer should be preferred over isoosmolar dimer because it has less risk of renal injury. What is the osmolarity of low osmolar? 600 to 800 milliosmol per kg, while isoosmolar is 290 milliosmol per kg. How much dose we give in pediatric patient? Up to 2 ml per kg. What is the iodine concentration? 300 to 320 mg per liter. Then in less than 10 years and in elderly patients, they have the lowest allergic rates, so the chances of allergy are comparatively less. Then what are the cannulas that we can use? So there are different gauge that we can use. So the size is 18, 20, 22, 24. The color is green, pink, blue and yellow, and the flow rate in ml per second is 5, 4, 2.5 and 1.5, like that. How you will treat the allergy if the child gets one? So if the child gets cutaneous reaction, you give diphenhydramine 1 to 2 mg per kg, IV or IM for cutaneous reaction. What is the side effect of antihistamine? Hypotension. If the child develops wheeze, you give inhaled albuterol 2 puffs, and epinephrine you give for laryngeal edema, bronchospasm and hypotension. How much dose? 0.01 mg per kg IV, slow push for 2 to 5 minutes. And what is the ratio? 1 is to 10,000. Maximum you can give 0.3 mg or 3 ml. Then how much barium do we use in barium sulfate? So when you do barium swallow, use 90%, barium meal follow through 60%, barium enema 30%. So it is very simple to remember, 90, 60, 30. Now when barium swallow you use double contrast, then double the amount, 90 ka double kar do, approximately it will be 200. Similarly in barium enema 30 ka double kar do, around you can reach 100%. Acha, how much you have seen microbar in your department? How much microbar, how much barium is contained in microbar? It is 95% weight by volume. Now, which oral iodinated contrast should we use for CT? Should we use gastrographin orally in child? No, because if child aspirate, that it can cause pulmonary edema. So you can use low osmolar contrast or you can use 2% barium sulfate. Acha, we know that whenever you are using positive contrast media, the system will sense that there is contrast media within the intestine and it will increase the radiation dose. What are the neutral contrast that we can use? We can use water, we can use sorbitol, because sorbitol also decrease water absorption in intestine, so the intestine will distend. Or you can use milk. Milk slows the peristalsis due to the presence of fat, so again the intestines will distend. So this was all about that we had to know in the pediatric imaging. I hope you liked it. So we completed first chapter, basics of pediatric imaging. If you liked it, please like the video and please subscribe to the channel, and please comment and please let me know if there is any other specific topic that you would want me to make a video on. So we will try to make videos like this. So first we are doing pediatric section, so I will try to cover the entire pediatrics, and then we can take the subsequent sections. Okay, thank you so much. Bye.